Good morning and welcome to our broadcast. My name is Carolyn Dubé. I'm the Executive Director at Fertility Matters Canada. And I'm thrilled to welcome you all here today for a really special webinar that we're able to bring to you by the generous help of EMD Sorono. So I'd like to introduce you to our panelists. Dr. Dan Nayot is a reproductive endocrinologist and a long-standing board member with Fertility Matters Canada. He's been with our organization for 6 years and is a huge supporter of patient care in this country. And Dr. Tom Hannum from Hannum Fertility Center in Toronto, also a huge supporter of our organization and of patient care. So Tom and Dan, thank you so much for being here. I'm thrilled to get things kicked off with you.
Thank you, Carolyn.
Thank you so much.
So we've had, as clinics have started to reopen in Canada and services are now starting to be provided, and we've had some discussions with patients and with physicians, and I'd love to know, maybe Tom, we'll start with you. How did the decision to reopen clinics happen? What was sort of the processes that were in place to sort of say, okay, we're ready to open in Canada?
So back in March, the CFAS recommended that everybody close, and they did so all of a sudden. I mean, we were all caught up in that, of course. It was a bit dramatic because everything was happening so quickly. It really did affect some specific patients who are going through treatments at that time. And then almost immediately upon that, the question becomes, well, how does one start to reopen? And there's a few things that happen. So across Canada, the medical directors across Canada created a committee to put guidelines into place for reopening. What would it look like? What would it be that we could do to keep everybody safe? It kind of boiled down to a couple of things. One was to make sure that the community was ready for us to reopen. So that was about making sure that we had enough PPE for ourselves, but also for hospitals and first responders everywhere. And secondly, that we were going to be able to do this and maintain social distancing to the standards that Canadians needed. So we were working hand in hand with public health at the national and provincial levels. So both were happening at the same time. Here in Ontario, we also had like an Ontario group who was meeting regularly, just like they did in BC and Alberta. It was actually out west that they were able to open first. It was about 10 days ahead of us. In Ontario, everyone was targeting sort of mid to late May, and some people were talking about June 1st, and then the provincial government announced that fertility clinics could be part of the first wave of reopening. That was May 18th, and I believe everybody opened as of the 18th of May. Dan, does that sound right for you guys? Is that how Trio handled it?
I think you nailed it. I think it was pretty coordinated, which is really great.
That's awesome. So in terms of patient, let's talk a little bit just about safety for patients, because I'm sure that that's a little bit of a concern for some patients who are coming back. I'd love to know, in terms of patient safety and clinician and staff safety at the clinic levels, what are some of the things that clinics are doing, not just at your clinics, but also at clinics around the country, to ensure safety of all people?
Yeah, Dan, do you want to start with that?
Sure. So obviously, it's up to the patient if there are going to be some patients who don't feel comfortable. So that's obviously up to you, and you can always call us when you do. But I think most people are feeling comfortable. At least that's what we're seeing. And some of the stuff we did is pretty obvious and logical. So things like just patient education. You've got a fever, cough, or been exposed to someone, please don't come in and please delay your treatment. That part is obvious. I think probably all clinics have some sort of screening system where, we check your temperature and we have a questionnaire to make sure you're not high risk. Another key part is, you want to keep that waiting room not just spaced. I mean, Tom has a beautiful place that you can space it out really nicely, but other clinics don't. But just even staggering patients when to come in. So maybe the flow will be a little bit slower, but it's safety to minimize touch points. I mean, everyone's got PPEs, like Tom was saying. So most of the stuff are pretty obvious, logical, but I mean, it took us a while before opening to do some dry runs to make sure it works well.
Yeah, those dry runs were helpful, and I think your point about the patient experience being different, even compromised, is real. When we look to safety, we're looking to sort of three different levels. One's pregnancy itself, just how safe is pregnant? How safe is everything that we actually do medically? Another would be safety from the patient and patient experience, coming into the clinic and what it's like as a caregiver to offer that service to you. And then the last part is safety within the lab. And I know patients don't see that part, but that was really important. That was the part that I was most worried about, that we were going to have to change lab processes around COVID, and we haven't had to at all, which is very reassuring. It's the lab processes that ultimately define success rates more than anything. And so behind the scenes, we really haven't had to change very much. The greatest change has been around patient interactions. And as Dan says, that's the challenge. How do you keep it a system that's efficient, but also helps everybody individually space and make sure that their individualized experience is both safe, but also you get in and out of the clinic in under 4 hours, right? I mean, at its worst, there could be a lot of we see that with businesses everywhere, don't we? Long lineups outside the hardware store. I've seen so many angry people standing outside of a Starbucks. Everyone's socially distancing in a very inefficient way, and we all recognize the complexities of fertility clinics. So I think what most clinics are, the way that we're handling this is we're starting slowly. So we're taking select patient groups and just trying it out with them so we can expand. And our intention is to be able to be fully servicing everybody within a matter of weeks, but it certainly wasn't that as of May 18th.
Great. So I think it's probably fair to say, correct me if I'm wrong, for patients to recognize and realize that, there may be some bumps on the way. This is a learning curve for all of us, patients, but also the clinics. And as much as you have put all of these pieces in place to ensure safety and efficiency and all that stuff, to be patient and recognize that everybody's sort of doing their best right now.
The way clinicians have always run their offices was just to have waiting rooms, right? The idea was everybody sits there and then the procedure happens, whether it's a blood test or an ultrasound. And that could be very efficient, but that efficiency came at a price of having a waiting room. Those are by definition not particularly socially distanced experiences. And so what clinics are trying to do is schedule things that used to not have to be scheduled. For example, an ultrasound might now be specifically booked for, say, 10:20 in the morning. And you can imagine that's not going to go well all that time. If the patient shows up at 10:14 or 10:23, now what, right?
Right.
So those kinds of things are going to be happening. As I say, I think fundamentally the safety of pregnancy, we can get into that later, but we're feeling pretty good about that. The efficacy of the lab experience is not in question. It's the clinical experience that's actually going to be the hardest part. The part that patients will feel, that'll be the hardest part.
Of course, yeah. So we've had some questions come in, and I'd love to touch on this one. We polled registrants about what they wanted to talk about today, and the number one question that came back was, what services will be available and what services won't be available right away? And that probably maybe is different for each clinic, but I'd love to hear both of your opinions on that.
I think it's going to be different for each clinic. What about you? What are you guys doing?
Yeah, I think so too. I think it's probably clinic dependent. I think what Tom touched upon is like probably most clinics are starting at a lower capacity just to make sure we can like evolve and then open up. At Trio specifically, I would say all treatments have been open. So things like embryo transfers, IVF, egg freezing, IUIs. We're trying to minimize the number of unnecessary clinic visits to the most mandatory ones. We're doing little things like, for example, I mean, a common would be like a semen analysis. So instead of having it in-house, we might ask somebody to produce it at home and then bring it in. We're trying to minimize like the number of assessments or partners coming in. But essentially, I would say almost everything. You guys, Tom?
Yeah. In the end, it'll be everything, but different clinics handle it differently. Through all that closure period, it wasn't just Canada that was closed, it was the US that was closed as well. Boston IVF, which is one of the leading groups, it's the group associated with Harvard, they limited themselves just to doing frozen embryo transfers and intrauterine inseminations. Other groups, when they're reopening, they're limiting themselves just to the IVF part, just to the retrievals. So there you go. You can have it either side. I don't. Each clinic's going to be different. I'd recommend that anyone who's listening, they just keep contacting their clinic. It's not unreasonable to contact a clinic on a weekly basis, maybe every 2 weeks if you think you're if you're not getting the answers that you need. But it's going to quickly change. Everyone's going to be quickly ramping up, and but each place will be idiosyncratic. Each place will do it the way that they think is going to be safest for their clinic.
Absolutely. Dan, you touched on a piece of this. We have another question just about, IVF is a lot of times a couple's issue, or any fertility treatment, I guess. Will you be limiting the number of, or will clinics be limiting the number of patients? So will only the woman be able to go to the clinic, or will she be able to bring her partner, or vice versa, a male, if we're doing surrogacy or that type of thing?
Yeah. So again, this is like clinic dependent, and you always want to balance like public safety and like patient experience. Like it'd be great to have support people. We put our threshold we're trying to not have a partner around unless needed. For example, like a sperm sample, or let's say egg retrieval, which is a procedure, and sometimes there's sedation. You definitely want a support person, someone to take you home too. So in those examples, yes, but day-to-day monitoring and things like that, we're trying to minimize it.
So we're doing the same thing. We're asking support people not bring a support partner, and I recognize that's a very significant thing that we're doing. One of the in the U.S., one of the first states to publicly reopen was New York State. It was actually during the height of the COVID pandemic in New York. Governor Cuomo put out a letter saying we support access to long-term birth control. We support access to abortion. We support fertility treatments, cancer care, endometriosis. We support women's health. And wasn't that far after that, they also said, and we support making sure that there are always partners available during obstetrical care, and by extension, all the way back to fertility. I recognize how important it is for people to be able to have their support partners with them at all times. And also, it does add an element of risk that so far at our organization, we're not willing to accept. We are struggling to keep patient volume numbers down. So before we closed, we would have about 200 patients a day coming through our clinic at various times through the day. And currently we're trying to cap it to 30. And that's, wow, again, just for patient safety reasons. Mm-hmm. So that includes, unfortunately, not having support partners.
Absolutely. Thank you for answering that. I think it's really important, and I think it's important for patients to set expectations in their mind prior to these treatments to avoid disappointments and, or unforeseen circumstances where.
Yeah, it sucks to not be able to bring your loved one into this experience.
Totally sucks.
Yeah, it sucks.
Yeah. So the second most popular question that came in was, what is the effect of COVID-19 on pregnancy? The potential risk to a pregnant woman, to an unborn child, to an embryo. I'd love to have a little discussion on that.
Yeah, that's the most important thing that we could be talking about, really. In all this, how safe is pregnancy going to be? When we first closed, I was worried about pregnancy for a number of reasons. One was just about how well hospitals were going to be able to cope. Just didn't really know, and it looks like they've been able to cope very well for a variety of reasons. Hospitals outside of the intake have actually been quiet for across Canada for most conditions, most procedures. People just aren't going to the doctor unless they absolutely need to, but that includes being pregnant. And so women who are pregnant have actually been receiving very good care across the country. And the Obstetrical Society of Canada, I'm getting some echo, something has changed. There we go. They've always been in support of pregnancy, and that's not just in Canada, that's in the US and Europe as well. So these days we're feeling very secure about helping people achieve pregnancy. At the same time, we're watching the literature quite closely. Dan, have you guys changed your counseling at all around safety of pregnancy?
I think that's right on. If I were just to zoom a little bit, it's yes, it is a virus and it's an illness, but it's very different from what you heard in the news several years ago, like Zika virus. Zika virus is like mosquito-borne, and there was pretty strong evidence that affected the development of the fetus, and that created this whole thing of like, if you travel to a at-risk destination, don't try to conceive. At the moment, there isn't anyone saying don't try on your own, and that extends to not trying through treatments. So that's one really important thing. The other important thing is like, we don't really know that much, but I think most of us, because it's 2020 and you can see how well we can track this right now, we're sort of reassured the fact that there isn't studies coming out showing something consistent. We think that's a pretty positive sign.
I
But
agree
again,
with that. Yeah, because as you say, it's not like Zika. Zika we found out right away, right?
very different from Zika. But you know, there are the, I guess maybe the, no, I mean, there's some view that like we'll only find out in a year because people were pregnant now, which is fair, but it's also probably already been 3 to 6 months of data collection, and we aren't seeing any consistent things like, hey, birth defects have increased or preterm birth have increased. And even the reports you will see, we're not really sure if it's related to corona or the fact that you had a fever, like the general flu.
You know, I don't understand though is I don't understand the relationship of COVID virus to blood clotting, and you know, pregnancy is always a time where we do have increased risk about blood clotting disorders for the woman or at the uteroplacental interface, and I know there's like just really small studies of like 16 women looking at the increased risk of clotting, and and I might have thought that was going to present itself clinically in different ways, and it just hasn't borne out yet. But I'm definitely following the literature closely for that. I guess that's my biggest worry.
Yeah, I think there's like the problem when we're talking about like the cause and effect. There's a lot of in between. What I mean is there's a few things we do know, like coronavirus affects a certain receptor called the ACE2 and then we take that information and there's a lot of that in the lung, so that makes sense. We take that information, we say, wait a minute, the testicles have this receptor, the uterus has this receptor, so we say, hey, maybe it can affect that. And then there's some studies that say, hey, we found it in the sperm, but that's different from saying, you know, this is sexually transmitted or this means anything like that. So we're picking up data points, but there isn't a consistent findings to tell us to counsel people otherwise.
I agree.
Great. That's really helpful because that's some of the questions that we get in, especially in our online support groups. You know, when the clinics were closed down, they said, well, why are we telling people to try to get pregnant naturally versus not being able to go into the clinics? And I know it was much more complex than just getting pregnant.
Yeah, I think the clinics were closed down because it wasn't clear that we could provide the services safely, not for our patients and not, you know, in support of the broader community. It wasn't really a question of whether or not fertility was safe, fertility treatments themselves were a problem or pregnancy itself. It was more just about delivering the service.
Yeah, I think that's really important to clarify because I think that there was some misconception that we were telling people to, you know, the fertile community that they could still get pregnant, but we couldn't get pregnant.
Yeah, it was right.
So
Super
it's a,
unfair. I know it made me crazy. Like the people who most needed to be able to continue their journey, and it really frustrated me when there would be flippant comments about, oh, there's gonna be a baby boom in 9 months, or don't worry about it, it's just 2 months. Well, it's not just 2 months. You know, it's 2 months of not being able to access, and then now it can be difficult to reach a clinic because you know because the clinics are busy. We can all recognize that we are all at risk of catching coronavirus. Most of us haven't yet, but when it does happen to us, it might take us down for a month or 3, you know, and so time can pass quite quickly. And I think this was a highly significant event for fertility patients. And
Absolutely.
I'm glad that everyone coordinated to get us to open back up as quickly as possible.
Yeah, the fertility community applauds you.
Tom, are you changing the counseling now for your currently pregnant patients? Like the ones, what are you telling them, like avoiding work and things like that? What's the current?
So we're not counseling people any differently than we did prior to COVID. We're saying that that the pregnancy experience should be no different than it ever was,
okay.
and that the public health guidelines that govern all of us, social distancing, mask wearing, etc., apply equally to women who are pregnant, no more or less than that. Yeah.
Awesome. So now that clinics are back open, what do you anticipate? And I know, again, this is very clinic based, are going to be the delays. So for patients, how are we getting patients back in? Are we prioritizing based on certain criteria? This is a loaded question, I know. I'm just curious to know what the discussions have been.
I'll start. I'm interested in hearing you, Dan, of what your guys' experience is. So we at our clinic, we follow all kind of metrics to help us understand what patients are looking for, and then try to match our services to what people want. So, you know, how many people are calling in looking for a new patient appointment, how many people want IVF, and make sure that we staff up appropriately for those different services. And all our historical metrics aren't working at all. So the number of new patients the number of new people calling in looking for care has dropped considerably. On the other hand, the people who are reaching out to us, it feels like everybody wants IVF rather than some of the treatments that are less likely to work. And so
Okay.
we're really struggling to work out exactly where to place our resources, and how that will play out to be a patient is sort of, I would anticipate different clinics across the country, sort of weird stumbling blocks. So it's sort of easy to access one aspect of care, but maybe suddenly there's a 2-month wait for some other part, because it's bumpy as we all try to readjust our service to this new reality. That's my expectation. We've only been open for a couple of weeks, so I haven't seen those problems arise yet, but that's what I'm anticipating is going to happen. What do you guys think, Dan?
Well, I think Tom hit some good original points there. Like, one of them is we're seeing a decrease of new consults because not that there isn't the demand, but people aren't going to their family doctors to get that consult. So
Right.
like Tom said, that's going to be a downwind effect. Also, when we're doing these like virtual consults and we say, listen, when we reopen, this is what you're going to do, we're going to see a downwind of, hey, how come it takes me so long to see Dan again after I did my test? It's because everybody did their test at the same time. And also, just like Tom said, we are seeing that sometimes the plans are changing because of the impact of, you know, time and fertility. There are a lot of patients who say, also like the fear of maybe the second wave, what's the most efficient way to receive, and we're changing our plans and we want to move forward as fast as possible. So that does cause a lot of changes, and any one of those changes, you got to connect with Dan or Tom to change the plan, right?
Yeah, so it makes for a bumpy experience, but I think it from an individual patient perspective, I really think it's worth trying to push through and trying to get that access to care. You know, we're not exactly sure how many Canadians have been affected by COVID at this point. Let's say it's 5%. It's probably not that high. That means 95% of people watching this haven't actually been personally affected yet. It's a really good time right now to be trying to get those embryos frozen or achieve pregnancy now, whatever it is that your goal is. Like, right now is the right time to be doing it, absolutely. So I hope that everybody's listening is ultimately able to access the care that they need, but it might take more phone calls than usual.
I bet.
Karen,
And are there any talks about prioritizing? Oh, sorry, Dan, go ahead.
You said your top 2 popular. I want to see the least popular question.
The least popular question? We can jump to that question right now. You'd be surprised, actually. I'm surprised at what it is. We'll touch on that in a bit. So are there measures in place to, you know, are you putting specific, in terms of getting people back into appointments and clinics, are you prioritizing, you know, by age or by last clinic, like the first appointments that were sort of started to be canceled? Or is this sort of, how's that working?
I'll say this, every time I've tried to prioritize, it's created a chaos and backfired for me, because there's not an objective way to prioritize. Does age trump financial concerns? Does financial concerns trump the number of kids you've had or how long you've been trying? Even though like the idea of it is nice, every time I've tried to do it, practically causes more problems, so I haven't.
Okay.
That's the same with us. We're not doing that. That's correct. Yeah. So as we've been opening up in stages, those have been a reflection of what we feel that we can do safely, not a reflection of what we perceive as the most important care or our most important patient. We're seeing everybody as the same, and my hope is that from the beginning of opening to the end of opening is just a matter of weeks, not just for us, but for all organizations. So that
Yeah, that would be great.
I think
And
that's what, honestly, I think that's what will happen.
so advice to patients, do patients contact the clinic to set up appointments, or do they wait if they've already been on the list for the clinic to call them?
Don't wait.
Oh,
That's my advice. Yeah.
that's great advice.
I mean, for some patients, I'm actually a bit surprised that everybody still relies on physically going to their physician to get a referral because it's 2020, but there's a whole bunch of virtual clinics on there that if you ever needed a referral, you can easily log on at home and get one done.
That's
Mhm.
a great piece of advice, actually, Dan.
You don't need to go to a walk-in. You don't need to do anything like that.
Yeah.
Great.
It's relatively easy.
Thank you for that. What about some of the financial pressures? Do you feel that because of this shutdown globally, that there is potential for patients to struggle more to pay or to come up with the funds to provide services, and B, will service prices increase at all? Do you predict that?
Okay, so I can speak to that because the physicians that all those meetings, those national meetings and those provincial meetings, that was a real concern because none of us know exactly what's coming financially, but it looks tough, doesn't it? It looks tough,
Yeah.
and these are exactly the times when you would hope there would be some deflationary pressures. That is to say, a reduction of costs to be able to help more people access care when they need it. At the same time, right as that's happening, our costs have increased like crazy. So all this the PPE stuff is a little bit of it, but the great majority of the problem is just limiting the ability of people to come into your clinic. So every time you do a blood test or do an ultrasound, that's when the clinic gets paid. And so when you do a lot less of that, then there's just a lot less revenue. And so what's going to happen is for the clinics is that there's going to be less revenue but increased costs. And so I don't know how that's going to play out as pricing for patients, but I think it is. We're all going to find out together over the next 6 months, and I think there's going to be, again, extreme pressures on both sides, both patients who need to access care and clinics who are going to be wondering how they're going to cover their margins based on the lower volume and higher PPE costs. Yeah, I'm not sure exactly how that's going to play out.
Dan,
Yeah.
would you agree?
Yeah, I think so. I mean, Tom is more connected to the provincial, so he can speak more about it. I mean, I guess some of us also have that fear of the funding program. You know, on one hand, would be like this.
Don't you? Like, I think the funding that we have is going to be. I feel like the government's going to keep that. The conversations that I've had with them feels like it's very on. Like that's something that we can definitely count on.
So I have no intel, so I would take Tom's comments more than mine. And I guess we fear that the government is struggling, so we're always wondering if they're going to take the pot from the funding to go to long-term or something like that. But that's just a fear-based thought. I don't actually have intel on.
Yeah.
Yeah.
But you're probably right.
It's a very reasonable question without great answers yet. I would suggest that clinics are going to be working as hard as possible to keep costs down, recognizing the reality that many people are going to be facing over the next while.
Absolutely. One final question. What about the mental health concerns associated with canceled cycles, the added financial burden? I mean, we're certainly seeing it in our online support groups. Patients are concerned, patients are struggling, patients are looking for more counseling services. Has that been something that your clinics have been helping patients with, or have you been hearing that from patients?
I think one of the, I mean, struggling with fertility is just terrible. And one thing I've learned over the years that the added variable of how long things take makes it so much worse. Like if you can have an embryo transfer every week, we'll get there very quickly. But the fact that you have to wait like sometimes several months for your next attempt just drives people crazy. And I think this just adds fuel to it. I mean, I can sense from what I'm seeing so far, like for sure the mental health is being impacted. Our sort of protocol is to sort of recommend counseling for anybody going through treatment. I think that's pretty common, only because we as clinicians probably aren't the experts in helping with that, but we could sort of guide people. But yeah, I'd recommend anybody who's feeling a bit stressed to definitely connect.
A good thing about these last few weeks is we've been able to reimagine different aspects of care that we're able to offer. So one of those is counseling, not necessarily related to specific, how many embryos you're going to transfer or whether you want to do an IUI again or not. Just bigger questions about how isolating this feels, or how you're coping with your relationship. How if you're going to be able to get through this together, what it's like to be needing to have a baby but also be worried about a job. These are questions that surround the fertility space, and there's now, because of the last 8 weeks, there's been increasingly availability of online supports. And what's exciting about that, of course, is it's not tied to a jurisdiction. So here in Canada, many people are separated geographically from a local clinic, but it doesn't matter so much now. So whether you live in Barrie or Squamish or Red Deer or Edmonton, you can access any of those online services, regardless of location. A close friend of mine is a psychiatrist, and she's been feeling that the counseling that she's able to provide online isn't the same. It's not quite as good as what it used to be in person, but also it's a lot more accessible. And she wonders if there's actually more good coming from the ability to access online counseling than ever before. So I would really urge anyone who's feeling really isolated at this time to do their research, to reach out. I know that you could contact Dr. Nyack's office or mine if you want some hints or some ideas about who to talk to, but there's a lot of services out there that are increasingly available virtually.
Absolutely, and we're seeing that as an organization. So Fertility Matters Canada, when COVID hit, we increased the number of online counseling sessions that we provide, and now have a more regular online support.
How popular are those, Carolyn? Like, are people
incredibly
using?
Popular. Yeah, we've done some private, so we do them via Zoom, and we work with the counselors that partner with us. These sessions are free, and if you're watching and you haven't participated and you'd like to, please reach out to our organization. Yeah, they're free, and they're a group setting, and we do them both as a sometimes they're as a presentation where people can ask questions similar to this webinar. And sometimes they're an open forum, and we have anywhere from 20 to 45, 50 people per session. So it's incredibly, very, and the nice thing, as you said, Tom, people from across Canada can join from the comfort of their home, their bed, with their phone, quite simply. So we will be providing more of those in the coming weeks and months. So it's really shown to us the importance of our work, that patients are looking for this type of support.
But that's funny, like it is funny with Zoom, isn't it? The backgrounds that people have, it's been quite funny.
Yes.
Yeah.
And this is not my house.
So we're going to take a quick break right now. We actually have a couple of questions that we're going to live poll our audience with. So in just a few seconds, we're going to have some questions pop on your screen. And please feel free to use your mouse or your finger if you're on your phone to answer these questions. So the first question is, was your course of fertility treatment interrupted or altered due to COVID-19? So it'll be really interesting to see, and we're going to get a live shot of the answers to this. It'll be interesting to see how many people on this session today have actually had a canceled or interrupted treatment cycle.
Caroline, I can tell you that the government was using polls like this to help. It's information like this that ultimately helped in Ontario, helped make sure that fertility clinics were amongst the first to reopen. Yeah, it was
That's amazing.
It was very much patient driven, and understanding what it was data like this that helped make the difference. Yeah.
That's really important, Tom, for you to mention that. And it looks, we've got 91% of our viewership today who have had an interrupted or altered cycle or treatment cycle. So that's incredible. Thank you all for being here. We hope you are finding this information useful and helpful. We've got another question. How do you feel about the measures that your clinic has taken in order to protect patients and healthcare workers? So in terms of healthcare workers, the doctors, the clinicians at your clinic from COVID-19. So some people may not have had an interaction maybe with their clinics yet. If you're looking for information on how to get into treatment cycles, but I'll be interested to see this.
I could walk people around I could carry the screen around and walk people around the clinic right now if they want. There's what is a very empty clinic and people in masks.
Oh, good. Well, look at this. 75% of the responses say they're satisfied with the measure. So I take that, and then 21% of them are neutral. So I think that that's a really a testament to what the clinics around this country are doing to ensure patient safety, pregnant woman, baby, unborn baby safety. So thank you to all of the clinics in this country for your continued work to ensure safety of all of our patients and the workers in the clinics. All right, next question. Has your clinic helped you to access social supports for coping with delayed treatments due to COVID-19? So social supports in terms of online support groups, access to counselors. And of course, that's some of the work that Fertility Matters Canada does. We help support clinics to get patients access to these supports. And so if you're out there and you're interested in getting more social support, please do contact us and we'll help you get access to those. We've got lots of online support groups, so we're happy to help you there. Okay, so this is kind of not quite split down the middle, but yes, 41% of people say yes, their clinics have been helpful, and no was 59%. So if you're in that 59% of patients who feel like you haven't been able to access those social supports, please do reach out to us on Facebook, on Instagram, on our website, and we'll help you get access to those if you feel that those are things that you need. But that's good information, Tom. Now I know that your clinics probably have active social media accounts, so I know that your clinics have been doing work to help give patients access to those things. But
maybe there's more we can do, though. I think that's a bit of an indictment of our field. I can imagine that we've been focusing on masks and hand washing and UV lights rather than the emotional side and making sure that people are getting the supports they need. I see that as a call for us to do better.
Yeah, I think that's good information for clinics to have, and we can maybe do some more digging as an organization to find out what other information or supports that patients would like and deliver that back to our clinics to help them access better information for your own operations.
Yep.
All right, last question. Do you feel ready to start treatments at this time? So I'm sure there are lots of people that are antsy and ready to get back, but I'm sure there's some patients who are, feeling unsure about if it's the right time for them. Yes, 83%. Wow, that's amazing.
Yeah.
I'm thrilled, and I don't know that I'm actually surprised. I feel like, as Dan touched on before, fertility is such an area where everything is unknown and you're always waiting, and so this has been a really unsettling time for a lot of patients. So I'm sure they're chomping at the bit to get back in and get things moving, especially knowing that sorry, I've got a slight visitor here. That clinics are doing a lot of stuff to ensure their safety and the safety of their embryos and unborn babies. All right. Dan, did you have anything to add there?
No, thanks for hosting us. I hope that makes sense for everybody. I think maybe we should have had two polar opposite views, but I feel like me and Tom are on the same page. We think the evidence is pretty comforting. I mean, we wouldn't have opened up if we didn't feel that way. you can imagine a lot of work came to do that, and yeah.
Dan,
That's
what do you think?
amazing.
Dan, what's in your opinion? What is the what are some unanswered things yet, or what are some concerns that you might have, either as a clinician or on behalf of your patients? I'm asking the question without having an answer formulated in my head, so I'm putting you on the spot. But I'm just trying to work out if there's anything that there's.
I think I get this. I mean, one clinical question that I think the physicians have is there going to be evidence that this sort of delay in treatment affected outcomes? Did some people get impacted by 3, 4, 5, 6 months of delay, like people who are older or lower reserve? I think we're all holding our breath, hoping that there isn't a study that suggests there's a pregnancy concern here, because that might affect things. And I think the entire world is just hoping a second wave doesn't come and close things down again. I do have a lot of patients who want to come in and quickly do things in case there's another wave. Yeah, I don't know. What about you?
I guess my worry is that my worry is that this is a different world. There's no such thing as perfect safety, and I think these are difficult decisions for people to be making. But I think that the right thing to be doing is to be accessing treatment now while you're healthy, now while we can preserve your fertility in time. For many people, we can preserve, freeze embryos or eggs or sperm, whatever it is that people need, because I don't think any of us know exactly what's coming down. And I want people to be able to take control over their moment. And my worry is that people are going to sit back a little bit and just kind of wait and see how this plays out. But I don't think that waiting is really going to do anyone any favors at this time. Tricky. I'm so sympathetic to financial worries. So I acknowledge I'm speaking to the medical side of it when I say that. But I hope that people are able to access care across Canada this summer, when we know that we can do this well.
Well, one thing I'm secretly excited about, I mean, one of my passions is like the fertility startup space. I just like seeing what everybody's working on. And I think, every time there's something like COVID, really neat innovations and technologies are coming out of it. So whether it's like, all the Zoom meetings, consults, there's going to be really interesting innovations, because I think
I agree completely. So like the virtual consults, but being able to increasing availability of being able to do blood tests at home, reduction in visits, a rethink of every single time that you had to come to a clinic. And what that might start to be able to do is open up geography a bit more. So if you don't have to go to a physical location as much anymore, maybe you can you'll have an opportunity to get the services that you need rather than the services that just happen to be around the corner. I'm actually really hopeful for medicine. I think we needed a shakeup. This is not how I would have wanted it to happen, but hopefully there will be some things that come from this that have long-term value for patients. I agree.
Yeah.
Yeah, that's a great conversation, because we see patients, that don't live in a city like Toronto, for example. If you're in the GTA, you have access to a lot of clinics, a lot of resources. But if you're in Thunder Bay, or if you're in Newfoundland or Prince Edward Island, you have access to very little. And so if we could help them with some of these things, I really believe that it's going to be huge for patients to access these types of services without having to go to an actual fertility clinic.
Right, because anything that we do to maximize safety, which includes not having to come to the clinic too much, by extension means that you don't have to be here or close by here. So I think it's going to have real implications for Canadians in particular, because we're so geographically dispersed.
Yeah, we actually had a question come in here live. It says, do you feel digital tools and educational videos will be the new era for patient education, consults, and treatment follow-ups?
I do, though. We've been making videos, and so far they suck. Ours are terrible. We haven't figured out how to do it very well. But I mean, yes, over time. So it's, I think we're all forgiving ourselves a little bit for Zoom with bad sound and other, whatever. But I think it is going to get better and better, and it's happening actually relatively quickly. Dan, I feel like I cut you off.
No. That's actually a good example. So, for example, obviously consents are critical. You need to make sure everybody knows And before, consent was so critical, we had to get both patients there live and sometimes with a lawyer and notary. But already very quickly, we've now used these like online things that's like saved the nurses so much time, the admin so much time, so we can focus on other things. So that's one of many examples where like, why didn't we do that 5 years ago? It was pretty obvious, because now we're forced to do it, sort of thing.
Yeah. Yep. Agreed.
Yeah.
I think that's great. I'm just looking at our other questions here. Sorry about that, you guys. In Ontario, this is obviously for the patients in that province. When should we expect the government-funded fertility program to restart? I know that they have a fiscal year of April 1st, I believe. So I haven't heard, like we sort of mentioned, that it would affect treatment, but do we know when those cycles would be starting up again?
One of the the leaders of the clinics were all in Ontario have been meeting on a weekly basis, and one of them back in February wrote to the funded program specifically asking that question, and the OFP team took great pains to craft a very well written response that was quite clear. The program has always been open. It's not going anywhere. It's as reliable as it ever was. They're hoping to help patients get access to care within the parameters that fertility clinics feel that they can do safely. So really, guys, nothing has changed for access to funding. The question's correct. The funding comes in every April 1st. So traditionally, that's when clinics would start spending the money, and many clinics end up running out of money before the end of, by the March 31st. That whole thing has just been transposed a couple of months. So I think there's going to be a lot more people having access to funded cycles this summer, for example, rather than in the spring. But I would hope and expect that everybody who needed and wanted access to funding before has exactly the same opportunity in 2020 as they were always going to. It was delayed by 2 months.
And do you feel clinics will be able to accept that volume to manage that? Is that a reasonable?
I don't know that. I can't answer that. I think that's actually very clinic specific. I don't know. I don't know that.
That's okay.
Yeah.
Dan, do you have any thoughts on that? It's probably, like you said, it's clinic specific, and
I think clinics are smart enough to pull back if it's getting overloaded or reversed, but I'd imagine they'd be able to.
okay.
Yeah. I mean, it's a very reasonable question because, our success rates are predicated on appropriate resources for every step. So it's really up to the clinic to draw those caps to make sure that they do so safely. But we all did it for COVID. None of the clinics were obligated to close. There was never a body that said that we had to close. It was all voluntary. Clinics were doing so in order to rebalance their services to ensure that they would be safe. So I believe that clinics will be doing the same thing, trying to provide access to high success rates. Does that mean that they'll actually have to turn patients away? I would be surprised, but I guess we'll find out together.
We have a question that's come in about the safety of sperm donors. So I'm curious to know, do you feel that can COVID, because we've heard a little bit in the news that there's some suggestion that it can live in semen. So is for donors, people who are going to donate sperm, is that a concern, or what should we be considering for those individuals?
So maybe I'll jump on. So yes, there's been some studies that say we found the COVID virus in the semen, but again, that's not the same extrapolation as this is sexually transmitted or this is an infectious amount of coronavirus. So nobody has sort of jumped and said nobody have intercourse, everybody wear a condom and things like that. I can't really comment on the sperm donor agencies themselves. Maybe I can defer that question, but I assume maybe going forward it might be part of their screening intake, but I don't really have info on that. Do you, Tom?
No, so far it hasn't been an issue because everything has been cryopreserved prior to COVID being present. To this point, none of the protocols in IVF labs have changed. So very specifically, whether or not it's donor sperm or donor egg, or it's your partner's sperm or your partner's egg, there are no specific criteria for screening people for COVID antibodies, no specific criteria for testing people for the viral RNA or antigen, because it's thought to be benign. So my expectation, based on where we're at today, is that it will not, there will not be specific screening for donor sperm around COVID. But I think that's something that we'll all be finding out in the next few months. I don't think it's clinically relevant at the moment, but it will increasingly be, I would argue, particularly for donor eggs. Because the sperm comes frozen, right? But a lot of donor eggs come as freshly donated eggs. So
Okay.
yeah.
Is there any correlation with an increase of miscarriage, or do we see any data on increase of miscarriage due to COVID-19?
So far, no, but I think there's two potential risk factors, which is why we're following this so closely. So one is any viral disease that's going to lead to extremes of temperature has always been a worry and a risk for first trimester loss. And then the second would be the association of COVID with blood clotting disorders. So we know that outside of the pregnancy space, people are worried that some of the events that have been associated with COVID are related to blood clotting problems. And so there's two reasons that perhaps first trimester could be affected, and yet we haven't seen it. Like, there just hasn't been those reports yet. The literature is broad. Somebody's going to report something soon. So just because there'll be one report that comes out doesn't mean that the issue's been settled. We're going to have to see a lot of things over time. But it is interesting that it's been this long now. 3-4 months, however deep we're into this, and we just haven't seen data sets anywhere in the world suggest that there's going to be a problem. So it looks like it's not going to be an issue. Yeah.
Mm-hmm. Dan, a question for you. What are your thoughts or advice for healthcare workers who are currently going through treatment, who work in more high risk or potential high risk environments? What would be some advice? I know it's hard to give medical advice over this way, but
I would say I'm not an infectious disease specialist or a public health officer, but I would say, there are certain screenings that we use, and whether if you don't make it because you're an exposed risk, like at work, then follow those screening. But do I think you should quit your job? No. Do I think you should stop working for several months? No. I mean, if you can afford that and that's not a big deal, why not? I know a lot of patients who take time off work while they're going through fertility treatments, but we don't have a criteria that if you work, obviously if there's at risk, like long-term care, or you're an airport security officer, it might be different, but then you would have already screened in our questionnaire. So I don't think I answered that too technically, but I
think that's helpful. It kind of eases your, because that's probably something that, especially if you're in healthcare or in these more high risk environments or hotspots, probably a concern, because you are more at risk.
Yeah.
Tom, do you have anything to add there? It's that.
Yeah, we're so our clinic's in a privileged position. Our lab has quality control out of Denver, so we're able to access some testing in the U.S. We're able to provide our patients access to COVID screening, even those who are asymptomatic. So we're not seeing. We have no reason to hold back from care from all frontline healthcare workers, but also. I know that Ontario is increasingly trying to make such asymptomatic screening available ubiquitously, so that lots of people are going to be able to get themselves screened. It's, just because you test negative today doesn't mean you won't have the virus tomorrow. But those kind of screening tests go a long way to helping reduce the risk and reduce the worry for all concerned. So I think the availability of testing is going to become broader, and it's going to help everybody who has particular worries be reassured that they can go ahead with care.
So Tom, you guys have COVID screening there?
Yeah.
Nice.
Yeah, we can do that without consuming Canadian resources. But as I said, I think we're all going to have that pretty soon.
And are you using that for certain? Is that you're routinely using that, or as needed kind of thing?
So say that again, Dan.
For the screening, are you doing that for like at risk, or for everybody, or as needed, or something like that?
So we want to be able to do it for everybody because there's so much asymptomatic COVID. But we're going to limit ourselves to mid-turbinate swabs, not the nasopharyngeal, because those are pretty brutal. You know, there is no perfect screening test, right? None of it's perfect. But if you're asymptomatic and your screening is negative, perhaps we can take some reassurance. Nonetheless, we're maintaining our same standards. We're still, we have everybody at the clinic in a mask. Everybody socially distanced. I'm not sure about you guys, Dan. You guys have been seeing my blue band. That's my, I passed my tests today.
No fever
today. No fever today, that's right.
And I think we're getting close to the end of the hour. It goes by quickly when you're talking about an interesting topic. How does someone, so for the patients out there, how does someone best advocate for their treatment with what feels like an overwhelming number of patients who may be trying to access treatment right now? I know that can be difficult, and it will, of
it's
course,
tricky, isn't it? Like, it's that whole, you know, how much do you want to be the squeaky wheel? It's on the one hand, we all want to be the good patient. On the other hand, we want to be able to access care, and it's quite scary actually. As a patient, you want to be able to, you don't want to provoke irritation, but you want access to the treatment that you need. It's a tricky balance, but I think it's very reasonable always to maintain a healthy level of communication with your caregivers, because it's always nice to be top of mind. And if you have some regular frequency with which you communicate, it's more likely that when a service does become open, that they'll be remembering you as one of the patients that they need to be looking out for.
Same for you, Dan. Any other advice?
I think that makes sense. I think both Tom and me are very for patients advocating for themselves. So yeah, I think number one is like education, which is what we're doing here. This is not like we're safely opening. We think it's the right time to do this. We are taking precautions to do it. But you know, if you have any questions, most, you know, proactive clinics have ways to get set up. But I know Tom's done a really good job with like educational campaign, and there's contacts there, and for us as well, where if you have any questions, you could just reach out to us. But essentially, you have to advocate for yourself.
Yeah, that's great advice. And as an organization, Fertility Matters would absolutely agree with both of you. We know that you're both very pro patient care and access to care in this country. So thank you for your time today. Thank you for your knowledge and your information. And thank you for your attention to ensuring that patients are safe, that your staff is safe, that yourselves are safe, and then hopefully any of these unborn babies who will come to fruition will be safe as well. So I want to thank everybody for joining us live today. And if you're watching the replay of this, thank you for taking the time to educate yourselves. We wish you the best of luck in your fertility journeys. We wish the clinics the best of luck as they are reopening and providing treatment and care. We will have a satisfaction survey at the end of this webcast that you can click on, and please, we'd love for you to provide feedback. It will also come in an email after if you prefer to take the survey that way. I'd like to thank EMD Sorono for their generous contributions to this webcast, for making it possible. And I'd like to thank, again, Dan and Tom for their time. Please stay tuned. We've got another webinar with Dr. Marjorie Dixon and Dr. Jason Hickory on June 18th. It's titled The New Normal, Your Post-Pandemic Fertility Journey. What we've been learning over the past several weeks as clinics are opening and we're hitting maybe some of these speed bumps, and what clinics are doing to help ensure continued safety and care. So thank you all so much. Stay safe, and we'll be talking to everybody soon.
Thank you. Thank you, Carolyn.
Bye all.
Thank you, Dan.
Thanks for hosting us.